you very much, Mindray and ACCLMP, to invite me to be a speaker on this interesting topic of COVID. I know we've been doing COVID webinars for a very long time now. There is a possibility that there might be, sharing of information which probably you might already be aware of. So pardon me for that, but there is also a lot of information which keeps creeping in and coming in, which is useful and might be helpful to some of our colleagues working in the COVID areas. So let me share my screen. Yes, so the topic that I'm going to be discussing with you all today is the hematological parameters in patients with COVID-19. Now, this is the place where I work, BLK Super Specialty Hospital, New Delhi. I bring you warm regards from here. And I must put in a disclaimer here and mention that the views expressed in this presentation are available primarily based on the available literature. There is a little experience that we have had at BL Kapoor Hospital, and of course there is some work which Mindray has been benevolent enough to share with me, which they had done with some scientific community and doctors in China, and I'll be sharing that information with you all as well. So just to make life easy and simple for my own self, and also for all of you to understand as to how I'll be going across on the presentation, I have divided my presentation into following 4 sub areas. The first one being hematology analyzer based data, and I have, if I may call it, stolen the term hemocytomorphometry from my mentor and friend, Dr. Sukesh Nair. So I'll be talking about the hematology analyzer and how that is helping us in COVID-19. I will be showing you some information about peripheral blood morphology. I'll show you some information about flow cytometry and how it is useful in SARS-CoV-2 COVID-19 disease state. And towards the end, we will also talk about hemostasis testing in COVID-19 disease. So I will start with a quiz, and I know I will answer it myself as well. So the question which I am going to ask here is, which is the most common medical laboratory test? And there'll be no prizes for this because we don't have one-to-one interaction here. But let me tell you, if you go to any field across the internet and try to look for one of them, which is the most common test being ordered across the globe, especially in a hospital-based setting, is a complete blood count, a CBC. Now, this could be, so people would say that, okay, you're just going to the internet and trying to figure out as to which is the common test. But do you think there is a common test which is available in literature as well? Well, yes. If you go to the literature also, you will be able to figure out that complete blood count is still the most common test that we use. I'm sorry, this is, yeah, so that's here. So CBC wins the prize. CBC is the most common test, and therefore, if there is an expectation from all of us to be able to get some information from complete blood counts as far as the COVID-19 disease is concerned, I don't think it's out of place. So let's look at the first part of it. That's the hemocytomorphometry. And in this part of it, I would like to first ask a question again, and which would be, which is a screening or a diagnostic test that would be most useful, which is recommended, and what is the guideline? Of course, there are lots of guidelines which are available, but what test could potentially be used for screening and diagnosis and monitoring of COVID-19? Now, if we look at these tests, the tests which are commonly talked about are the antibody and the RT-PCR based tests. But can CBC be a screening test for COVID-19 is a burning question. And I know a lot of you would know the answer, but as we go along with the presentation, probably we will be able to understand as to what we are talking about. So this by far is the slide which I would prefer to make you remember, and that's like RT-PCR on a viral RNA still happens to be the most important test for diagnosing COVID in our country and elsewhere across the globe. And with its own fallacies, which it has, especially with respect to sample collection and the stability of the RNA, etc., it sure has issues within itself. So therefore, if you would be able to get a test which could give us information right at the click of the button, that would be wonderful. So now let's go to the Mindray analyzer, the data from the Mindray analyzer, which has been benevolently given across to me by the Mindray headquarters, shows very clearly these data points which you are able to see on your screen. Now this is a screen which has been taken from BC6900, and what you're able to see is the differential plots right in front of you on the top. And down here you have the platelet and the RBC curves, and there are three distinct patient sets. These four graphs belong to one, and likewise the other four and the other four belong to the other different group of patients. Now, when you look at these figures which you're seeing, or the pictures you're seeing in front of you, there is only one thing which I'm able to make out here is this small little dot-like population, which we used to talk about high fluorescent cells. Again, in this one also, very tiny population. Here as well, some small little fine dots. Other than that, when I look at any of these parameters, I'm really not able to get any specific information to say that this analyzer or a hematology analyzer based data is really going to give me some great information. So having said that, there is also the numerical data which keeps coming out, and a lot of us are actually interested only in the numerical data. So if we look at the numerical data, what's obvious in all of them is that there is lymphopenia in these two cases, there is an increase in the RDW, and what is very important is that the platelets seem to be normal in all of them. And there is this interesting parameter called neutrophil to lymphocyte ratio, which is elevated in patients with COVID. And as you become better, the neutrophil to lymphocyte ratio also comes down to nearly normal. So let me tell you, all the three sets of data which you're seeing here are from COVID patients. This has happened in China. And in all the three sets of patients, one is a severe one, the first one. This is moderately severe, and this is the kind of mild disease. Now, my wish list is, what we have seen in the past, and my colleague, Dr. Tina, had shown us in one of her presentations, as well as in her publication, which is likely to come soon, where she's shown that, high fluorescent cells would be something which would be able to give us information with respect to dengue. I wish there was something like this for COVID as well, or maybe something better. And that would make our life so easy for just looking at that particular information and saying, okay, guys, this is likely to be dengue. Now, unfortunately, so far, that's not the case. I was looking at the data which is coming from other analyzers being used in COVID hospitals or COVID settings. And what I found very interesting was the information which was on ADVIA 2120, where they talked about myeloperoxidase deficiency, which was a partial myeloperoxidase deficiency coming out in these patients. And along with that, you have the lymphopenia. And if you notice in this particular graph over here, the neutrophils are actually shifting towards the monocytic region over here. That's this purple one going into the pink region. And there is obviously a data plot which is not giving us very concise or a confined information. Now, if we look at the data which is coming from a typical CBC analyzer, and as the disease COVID-19 evolves in an individual, what is very striking is that you are getting a neutrophilia, as you can see in the first graph, and this neutrophilia is obviously concomitant with the total WBC count. And at the same time, you're also having reduction in the lymphocytes, and the lymphocyte count goes down significantly. So I'm not sure how many of you know about the IPF. In the IPF would keep on going up as the platelets would go down. And if we make it akin to what we have seen there, here the neutrophils keep going up and the lymphocytes keep going down. And my thought, this is my thought, is that the moment your lymphocyte count becomes stable at whatever lowest possible count, this count is likely to come up the very next day. And that's what my possible postulation is, though this is a bit too early for me to predict at this point of time. What is very obvious also is that the neutrophil to lymphocyte ratio gets increased, as you can see here, and you're also able to see at the same time their correlation vis-a-vis the CRP. So this is very characteristic data which is coming out for all these patients of COVID, and this is coming from a typical hematology analyzer. There is also very interesting information coming about neutrophil to lymphocyte ratio in COVID-19. And this is one paper which I'm quoting in front of you, where they have actually looked at segregating patients of pneumonia, COVID-19 pneumonia, based on the age, and then subsequently based on the NLR, and actually isolated the patients. They have also looked at, if you look at these curves, how they have fared, in terms of their survivals, with the lower survivals for those having a higher NLRs. So if you look at this picture over here, what's obvious is they have divided the two groups into age less than 50 and more than 50. And then based on the NLR, they have decided whether they want to keep them in community hospital or isolation at home or in general isolation ward. And likewise for more patients with more than 80 years of age, again, based on the NLR of 3.13, they decided that cutoff and went ahead. Now, this is one interesting parameter which the Mindray guys have developed by using the logistic regression. Don't ask me what exactly it means and how exactly they have calculated it, because this is something which they are trying to get a patent for. And they have observed that when they have a parameter of NLR and RDWSD, and if it's more than 1.06, it is likely that the disease will be more severe. So if you look at this data, which you're seeing in front of you, the regression analysis curve, the sensitivity and the specificity of this particular parameter, NLR-RDWSD, gives you a very high area under the curve, and it is obviously giving you very high sensitivity and specificity both. So they have recommended NLR, that is the neutrophil to lymphocyte ratio, with RDW as an indicator. And if the value is more than 1.06, it is likely that the patient will deteriorate. And if the value is less than 1.06, it's likely that the patient will either remain in the moderate condition or become better as far as the disease state is concerned. Now, there are other parameters also which are looked at the same time. This is again, these are studies which I'm quoting from Mindray headquarters itself. And in this study also, they have observed that the neutrophil count will be, lower in terms of a severity of the disease, and higher in case of disease which is very severe. There will be more lymphopenia, which will be more pronounced in the severe disease, and RDW will be much higher in a severe disease. So what is obvious in this case is that there is neutrophilia, there is lymphopenia, and there is increased RDW. Now, none of them are a specific parameter, because all this can also be seen in severe sepsis. There is another study which was also done by the group on Mindray, from Mindray, where they grouped the patients into three primary groups of group 1, 2, and 3, of mild group, severe patient group, and critically severe group. And they also then eventually added two more groups where they talked about prediction of severe patients group, that consisted from the group of group 2, and also prediction of the critically severe patients which were coming in from group 3. And all of these groups they eventually looked at with various parameters which were coming from the hematology analyzers, including the research parametric data. And as I pointed out earlier as well, there is no significant data which is coming from any of them, except for the fact that there is a monocytic Z value, wherein the Z value increases and that is talking about larger monocytes. And this has also been seen subsequently in some other studies, which I'll be quoting up later. It has also been noted that as the monocyte Z value increases, the disease severity increases, but when it's extremely severe disease, that's group 5 disease, the monocyte Z value goes down. There is another very interesting parameter which they have tried to look at, and that's the lymphocyte, absolute lymphocyte with RDWSD parameter. And they have professed it to be a parameter which can be used for prognostication of severe coronavirus patients based on the data that they have. The total number of cases which they looked at was 57, and they differentiated between the mild and the severe disease and saw what was the outcome. So what's obvious is that when you have a high WBC count, you have a worse outcome than when you have a relatively lower values. And the lymphopenia itself, you have a lower severe lymphopenia, your outcome is going to be bad as well. Same thing is about with respect to the neutrophil, absolute neutrophil count, as well as the hemoglobin. So if your hemoglobin is low, you are more likely to have a severe disease. They also looked at value of neutrophils to lymphocytes and also looked at the RDW, which is almost akin to what they have shown in the previous slides. So if you look at these parameters, you are able to figure out that when you look at these parameters, there is a very distinct parameter of lymphocyte absolute counts with RDWSD. And when you take this parameter together, you are able to differentiate two distinct groups, one of those which is severe with good outcome, and the other one which is severe and a bad outcome. So this is very distinct, what is obviously seen in your screen at this point of time, and gives a very interesting parameter from the hematology analyzer itself. And this has also been done basis the logistic regression, which is a statistical tool of handling it. And you can see how the formula has been derived, and they looked at a value of more than 0.794, and that may be a good indicator of severity in patients infected with COVID-19. In addition to this, there were other studies which I saw on the literature, and they talked about how they have been using the time and the lymphocyte percentage model to segregate patients into various subtypes, and also looked at how they eventually got cured or went into an ICU. So if you look at this, They took two distinct time points, and then in these two distinct time points, they looked at the patients which were moderate, which were severe, and which eventually also died. And if you look at this part of the slide over here, what you're able to see is that the first time point, that's day 10 and 12, they were able to differentiate between moderate and the pre-severe disease based on 20% lymphocytes cut off. All those who had more than 20% lymphocytes, they got cured. And the ones who had less than 20%, they took a second time point at day 17 to 19, and then they divided them into three distinct groups, wherein they had moderately severe who got cured very easily, the ones who had less 5 to 20% lymphocytes who got eventually cured but took a longer time, and the critically ill patients whose lymphocyte percentage were less than 5%. So obviously, somewhere people have actually attributed everything to the lymphocytes, which may perhaps be something which one can exploit while dealing with such patients. This is a slide which I have shared earlier also in one of the presentations which I did for Mindray. What is very obvious in this data set which has come from this particular group, they have observed that when you're looking at patients, who are having the white cell counts, and the neutrophil count and lymphocyte counts, and also D-dimers at the same time, the patients who did worse obviously had a much higher white cell count, as has been seen in this particular graph. Their neutrophil counts were also higher, and they had a much severe lymphopenia, and they also had much higher D-dimer levels. Obviously, we are all talking about something which is basically indicating that there is some septic stuff happening within the patient. This is another important point which I'm going to show you here, and this is about those patients, where lymphopenia is the survivors versus the non-survivors. The lymphopenia was much more severe, and at the same time, the D-dimer levels were elevated, and so were the levels of ferritin. All these are markers of inflammation. I would not be doing complete service if I do not mention about this. This was a very interesting thing which I went across, when I was trying to make this presentation, and I was already knowing that somebody was talking about saying, hey guys, this COVID-19 is a hematological disorder and it's affecting the hemoglobin. And of course, a lot of information came into the WhatsApp and the Facebooks and stuff like that. And when I laid my hands on this paper, what I realized is that this paper is only for academic purposes. It's been primarily a paper which has been done on experimentation, and this needs to be really proven. However, what is important is that the viral non-structural protein does attack heme on the beta chain of hemoglobin, and there could be a possible explanation based on this paper. This is the data, which seems to be a busy and a small font slide, but it's again the entire collation of what I have just shown you in the previous slides. And this has been already published in the American Journal of Hematology, where they have spoken about the neutrophil to lymphocyte ratio. They have spoken about the WBC counts, and they have also spoken about the other parameters which are important from a CBC analyzer. Just to show you this data, which was shown from the Italian group, where they again talked about white blood cells and neutrophil counts. Again, as you can observe from the p-values, the parameters which are of paramount importance, the total WBC counts, the lymphopenia, the CRP, and at the same time, the LDH values. So if I conclude this part of my session, what are the conclusions from whatever I just mentioned? Number one, there is no specific parameter in hematology analyzers alone to really tell you whether you're dealing with a COVID-19 or not. Lymphopenia, sounds to be a very interesting parameter in this clinical setting, and it is relevant only when there are other supportive investigations there. Like for instance, if there is an increased anti-proBNP, or there is a troponin I which is high, and there is elevated levels of D-dimer, LDH, and other radiological findings like shadows on the X-rays, you can suspect a COVID in such cases, and we have observed this in our center as well. You can combine this with CRP and some other biochemical investigations, including ferritin, and this may even help you to suspect and prognosticate. And the promising parameters, especially the NLR, which has already been discussed by many other people as well, including these two other interesting parameters from Mindray, that is the NLR with RDWST and lymphocyte, absolute counts along with RDW, seem to be a very prognostic set of markers which might be able to help us, if not in diagnosis, at least in the prognostication of the disease. So now I move on to the second part of it, and that is the peripheral blood morphology of these cells. What my wish would be that if I would look at a peripheral blood film of a patient with COVID, I would be able to tell them, guys, this is a specific indication or a specific thing that I'm seeing in this particular COVID disease. Now, when I look at the information which was available from many people who've been dealing with COVID across the globe, what is the most revered person who you look up to always is Barbara Bain. And this is one of the papers which has been published in the American Journal of Hematology, where it shows the presence of these lymphocytes. And guys, tell me, don't you all see these kind of lymphocytes, in a typical dengue viral illness as well? So these are nothing but plasmacytoid lymphocytes, which are otherwise called virusites. Once upon a time, they would also be called Downey cells. And these cells are very obviously seen on a peripheral blood film. But what is very striking in this case is you are able to see platelets, which are absolutely normal in the background. So therefore, platelets are really not affected early in the disease. And yet you have these reactive lymphocytes. Now, presence of these reactive lymphocytes is not specific. Okay, what else do you see? As you see the disease progresses, you are able to see all these changes in the peripheral blood film. These are your granulocytic precursor cells. This is your reactive lymphoid cell. Again, a myelocyte here. And this dysmorphic neutrophils, which you're seeing all across, this is from one of the papers which was published about morphological cells, the morphology of these circulating cells in COVID-19. And what is very obvious is the dysplasia. If you remember, I had shown you in the CBC analyzer also, on the ADVIA one at least, that there was some degree of dysplasia which was picked up. But mind you, all these changes, what you're seeing, these dysplastic changes which you're seeing in this particular picture, is usually seen as a later phenomenon. It happens in moderately severe to severe disease and is not seen in asymptomatic individuals. Just to show you some other things which can happen potentially in cases of COVID-19, you can see shift to the left, which is obviously shown in the previous one as well. You have these monocytoid lymphoid cells, and of course you will have giant platelets as the patient moves on into the phase of sepsis. What was very interesting, and which has also been proven subsequently by flow cytometry, which I'll be showing you later, is the presence of these large monocytes, which you are very easily able to see here. They're very large in size, very reactive, having these vacuolations within the cytoplasm, some degree of fine granulation, which you're able to see, and the nucleus, which is like kind of opened out. Uh, if the cytoplasm would not have been so much, I would have been worried, are they promonocytes and is this something like an acute monocytic leukemia? But anyway, what happens is, what is characteristically seen in a typical healthy donor is what you see in this first figure. And as you see in all these patients, these are at various stages, somebody who's at mild disease to moderate disease and severe disease. These three pictures in the end are from the severe disease. So these monocytes, the moment you see in a patient of COVID-19, you will be able to say with high degree of authenticity that this patient is likely getting into a severity of the disease. Again, this is from another paper from American Journal of Hematology. Here again, you're able to see morphology, which is showing dysplasia. These are all in the later stages of the disease. You can also see these four pictures on the bottom, which is from A to D, where you're seeing nucleated red blood cells, reactive lymphocytes, shift to the left, and this is like a typical leukoerythroblastic picture, which you're observing here. So when I look at the peripheral blood morphology, all these features can be seen in many other diseases as well. So if I conclude the morphology part of it, again, on the peripheral blood film alone, there is no specific parameter. The morphology varies from normal to neutrophilia, dysplasia to leukoerythroblastic picture. But if you actually see large monocytes, it is usually a feature of deterioration of clinical picture and usually a feature of severe disease. This eventually obviously might help us to prognosticate the disease. Okay, that takes me to the next part of my presentation, and that's flow cytometry. I'm sure some of you would have probably attended my previous talk as well. So this is nothing new. I'm showing you the same stuff which was shown the last time. And in flow cytometry, what is very characteristic is the presence of these large monocytes. They're very distinct, and you can see them on the forward scatter and the side scatter as a distinct cluster of cells having a very high forward scatter. And this is what was seen even on the hematology analyzer research parametric data, where the mono Z was higher. And that's the size of the monocytes, which was pretty high. And as you are observing in this particular case, as the patient was treated, these cells became lesser and lesser in number, and eventually the person became all right. This is the morphology which was seen in patients at different time intervals. And the p-value in all these is pretty significant. What is again very, very important is all these monocytes which you're seeing there, whether on flow cytometry or morphologically, it is also important to note that all of them are from the monocytic lineage, because you're able to prove that by putting up these monocytic markers. And what is again very important is in all of them, you are able to demonstrate the markers of activation. So what am I trying to say? This is a time when the patient is actually getting into what is called the macrophage activation syndrome, or what is called the cytokine storm, and all these will follow eventually, all of that. So these are various patients at various levels of the stage of disease, some who are having a very early disease and some who are having a late disease. And as the disease progression is there, you are able to get higher and higher number of monocytes on flow cytometry. And importantly, as you treat the patient, you will be able to get better results on the patient, because the monocyte counts will start going down. What they have also tried to do in this particular presentation, in this particular study, is that they have tried to assess this kind of monocytic component in other viral and other non-viral infections where they're having febrile illnesses and stuff like that, and they were non-COVID. And they observed that in others, even though they may be there, they're just too minute in quantity to be really picked up, and they needed to really take up a higher quantity, higher numbers of events to come to the conclusion. What is striking is the presence of the ACE2 receptors on these cells, and they have been able to figure that out very clearly. So you are able to pick these cells with ACE receptor positivity, which is also considered to be one of the important parameters for COVID infection. And this is also about the activation markers, which I told you. The activation markers are also positive on the lymphoid cells, whether we talk about T cells, the B cells, and at the same time, it's also observed on the monocytes. These are the other markers which are also importantly seen there. What is striking though in the lymphocytes, despite having lymphopenia, the CD4 to CD8 count does not really get altered. So this is what I'm showing you in these graphs over here. What you're able to see is that, when you have a healthy control, this is the status. HC is healthy control, and these are your COVID pneumonia. So if you look at COVID pneumonia, you're able to get a CD3 count and a CD4 count. Both are lowered, but if you look at the ratio remains constant. You're having a lymphopenia vis-a-vis the B cells. You're having lymphopenia vis-a-vis the NK cells, and of course the total lymphocytes are also reduced. But characteristically, the CD4 to 8 ratio remains almost normal. And this is also seen with respect to the severity of the disease. The more the severe the disease is, the more is the effect on the cells. And this is very, very obvious. But please note, CD4 to 8 ratio really, really does not get altered much. And as you treat the patient, there is a recovery. And this is observed in all these graphs. Most of these cells will come back to normal. So if you look at the area under the curve, CD4, CD8, CD3, CDT, all these have almost near similar sensitivity and specificity, and they are able to give you very clearly lymphopenia per se, and all pan-lymphopenia, if I may call it so, because it affects all the three lineages, the T, the B, and the NKs, is able to give you an indication that perhaps you might be dealing with COVID. Again, from another paper where similar findings have been seen. So I will not really get into details of all that. The only important point what I would like to make is 4 to 8 ratio remains kind of normal. So if I conclude the flow cytometry part of it, there is again no specific parameter on peripheral blood flow cytometry. However, lymphopenia is something which you can easily pick up on a hematology analyzer, and you can look at the CD4 to 8 ratio. If it is well maintained, you are more likely dealing with COVID. Important point, large monocytes with macrophage activation markers is a feature of deterioration of clinical picture, and is usually a feature of severe disease, and thus may help in prognostication of disease. I come to the last part of my presentation, which is about hemostasis testing. So if we look at hemostasis abnormalities in COVID-19 in patients who are asymptomatic, you will be able to find nothing at all. They are absolutely normal and have absolutely normal symptomatology, absolutely normal hemostatic profiles. But as the disease progresses, what you are able to observe is in all of them, you have prolonged prothrombin times, and almost in nearly 70 to 80% of them, you will have prolongation of activated partial thromboplastin time, and you will have significant increase in D dimer and fibrin degradation products. Now, this is primarily happening because there is consumptive coagulopathy or disseminated intravascular coagulation, which is setting in COVID-19, and that's what usually is the cause of the disease of the death in a lot of patients. What is being shown in this particular slide, I'm sorry, I have not put a reference to this particular slide, but anyways, it's there in from the literature itself. What is very obvious is in this is that in all of them, I've shown all these are the ones, whose presentations, and this is a meta-analysis which had been done, where you're seeing that the platelets do not really get affected in most of them. And only one study has shown an effect on the platelets, whereas APTT, PT, and D dimer is getting affected in almost all the studies, and it's very uniformly seen in all of them. What is striking, as I told previously, is a D dimer. And with respect to the survivors and the non-survivors, you are able to figure out that the D dimer levels are much higher in the non-survivors. And as the D dimer, so therefore, if I would have to follow up a patient, I would like to do a D dimer levels regularly and like to see a trend in that. If the D dimer levels are stable or are coming down, I know my patient is going to recover. Now, there is another important aspect, which is about DIC scoring. And if you, I'm sure all of you would know that platelet count, D dimer, fibrinogen levels, and prothrombin time are the ones which are looked at. Now, remember, there is a marked difference in the frequency between survivors and non-survivors when you compare this DIC score. So DIC score is much worse in the ones who are non-survivors. There is another important aspect which a lot of people ignore at this point of time. A lot of patients are on warfarin during COVID-19 restriction, and there is still a lot of confusion as to what should be the ideal methodology of monitoring them. And of course, a lot of people would prefer to monitor them at home itself, and trying to maintain the INR within a range what is specific for that particular disease. Having said that, there is also a thought where people talk about putting them on the newer direct oral anticoagulant therapy and trying to on the faith, on the belief that you don't need monitoring in such cases. But anyways, the verdict is not yet clear, and we are still confused in this part of it. Now, as far as thrombophilia profile in COVID-19 is concerned, we know that there will be significantly higher fibrinogen levels, and we also are aware of the fact that fibrinogen is basically nothing but a inflammatory marker, and therefore that level is high. We have also known so far by now that D dimer levels are pretty high. And what is very interesting to note is in one of the articles which have worked on ROTEM have proven that there are shorter clot formation time in INTEM and EXTEM and a higher maximum clot firmness time in INTEM, EXTEM, and FIBTEM. In all these cases, what does it mean? It simply tells you that there is a hypercoagulable state. There is also only one article which is available in literature, at least at this point of time, which talks about antithrombin 3 deficiency. And there is also a postulated reduction in the protein C, which makes a person far more prone to developing thrombophilia. Other coagulation abnormalities include prolongation of prothrombin time and activated partial thromboplastin time. There are increased fibrin degradation products, and severe thrombocytopenia is usually seen in a very severe disease where the patients are already on ventilator, and this usually indicates a disseminated intravascular coagulation. So if I conclude my part 4, there will be D-dimer elevation, there'll be and serial count testing of platelet count, prothrombin time, activated partial thromboplastin time, fibrinogen, and D-dimer would be important for us to differentiate between those who are actually going into DIC by looking at the DIC score as well, and will also help us to prognosticate. So finally, a take-home message. The take-home message is, if you look at COVID-19, it's a systemic infection with impact on hematological system and hemostasis. One needs to be wary of the cytokine storm, and that's where we need to be very clear as to how we'll be able to pick them up. Lymphopenia is one of the most important cardinal laboratory finding in hematology and has a huge prognostic potential. I had shown you the graphic data where we saw that if it becomes stable and then increases back to the normal, then it's likely that the patient will recover. Neutrophil lymphocyte ratio, peak platelet to lymphocyte ratio, NLR with RDW, and lymphocyte counts with RDW, all these are very interesting parameters which have a prognostic significance rather than a diagnostic significance. Blood hypercoagulability is very common, especially among hospitalized patients in COVID-19, and that needs to be taken care of. And that is where perhaps thromboelastometry based platforms like TEG and ROTEM would be useful. And elevated D-dimer levels are constantly reported, whereas their gradual decrease during the course is particularly associated, increase is particularly associated with disease worsening. I would thank you all for your patient attention and would be happy to take questions, if any, at this point of time or later in the question answer session. Thank you very much. Priyank, over to you.
Yes, thank you so much, sir. I think you covered the all the aspects more properly. So, Dr. Sen, I would request you to start sharing, please.
Yeah. Okay, fine.
प्रियांक शर्विष्ठा मैडम का ये वीडियो ऑन करो। Start.
We can see you.
Good evening, everybody.
Good evening, sir. We can see the screen, sir. We can continue.
Okay, so should I start? Hello. Hello. Yeah. Good evening, everybody.
मोबाइल में कुछ चल रहा है अपना मोबाइल में कुछ हेलो अभी ठीक है अभी ठीक है अच्छा सर अपना स्क्रीन नहीं देख पा रहा है अभी शायद साउंड ठीक हुआ है सर खुद को नहीं देख पा रहे हैं देख रहे हो सर को ओके क्लियर हाँ सर ठीक है
Should I start? Yeah, but my camera, I'm not visible in my camera actually. Anyway, so good evening, everybody. So my topic today is biosafety guidelines and role of biochemical markers in combating COVID-19 menace. And after such a wonderful lecture, rather it's a baseline information based lecture I would like to carry on. And basically we'll be starting with the very basic things, the biosafety guidelines of during the COVID, although it is not, it is basic but very important. So first, in a nutshell, I should say that we all know that nowadays the SARS-CoV-2 is our big headache. The entire world is stopped basically with the fear of this infection, and therefore it spreads with the respiratory droplets, and
also with contamination through infected surfaces, and symptoms of fever, cough, and breathing difficulty. And this high risk are actually people more than 65 years of age and other comorbidities. And unfortunately, other than hydroxychloroquine prophylaxis, we hardly get any specific treatment so far. So therefore, the best thing is to not to get infected by it. So the general guidelines about the standard precautions when handling clinical specimens are: first thing you need to do is a hand hygiene and also use of personal protective equipment. That's the most important thing. And as per CDC, healthcare personnel are recommended to wear a form of source control. That means at all times while the in the healthcare facility, this source control, that is avoidance of contact, is the best thing. And therefore you have to have some risk assessment done. And risk assessment, and accordingly you have to take some steps for that. And that depends on which procedure you are performing and what kind of hazards involved in the process, the competency level of your person who is performing the procedure, the facilities, equipments of your laboratory, and also the resources available for that. So therefore, the basic tenets are all procedure must be performed based on risk assessment and also on the basis of the capability of the personnel. So who is actually performing the function. So therefore, the initial processing of all specimen should be in the biological safety cabinet or primary containment device. And you can actually differentiate between a non-propagative and propagative work. So the non-propagative works are general diagnostic laboratory work, which can be sequencing and NAT also, and should be conducted with a BSL-2, under BSL-2, and what is called propagative work, which is a virus culture, isolation. These kind of work should be in a containment laboratory where inward directional airflow or equivalent to biosafety level 3. So now other things are that very important thing is the disinfectants. So there are, this is actually all enveloped viruses which act on, which actually are disinfectants which are effective are, these are, as you know, hypochlorite or bleach, alcohol, usually between 62 to 71% alcohol are very good, hydrogen 5% hydrogen peroxide or quaternary ammonium compounds or phenolic compounds, they act good as disinfectants. So these should be used to contain the or make it the area disinfected. Now therefore there are two specimen I should be saying that those specimens from suspected or confirmed cases should be transported as category B, and like viral culture or viral isolates, you should be transporting is as category A. Now, according to the job of a common laboratory, I'm talking about a common laboratory which is performing the tests of COVID as well as a general all category of tests. So for them, we have the risk categorization are actually divided among the low, moderate, and high. So we are taking in account a low to moderate risk category together. These are like collection of blood, urine, stool sample, sample receiving area, diagnostic testing of serum, blood, and urine and stool, including all hemat and biochemistry sections, and the histopathological examination, except those of frozen section biopsy. These are coming under low to moderate risk. And high risk procedures are anything collection and processing of the respiratory samples and frozen section biopsy. Why I'm giving frozen section biopsy of so much importance? Because it generates aerosol during the process, which is a very dangerous process. So these two are taken in a high risk procedure. Now, if we go with the precautions required, for those high risk procedures, we should have a full PPE that should have an N95 or a 3-ply mask equivalence to that. And for routine laboratory procedure, which categorizes low to moderate, you can have a standard precautions. And now, this is what the recommended rational use of PPE in routine laboratory. Like those areas we call high risk areas, or which they are who collects respiratory samples, whatever, nasal, oral, whatever, or aspirates and FNAC of head and neck region. They are taken on a high risk category, and the recommended PPE is a full PPE. Moderate risk like front office, receptionists, lobotomists, technicians, working in microbiology, or any staff who deal with patients and respiratory samples are categorized as moderate risk, and they should wear double layer gloves, lab coat with apron, and N95 mask or equivalent. There is actually not universal recommendations. In some areas it is called N95, some are calling it there is no requirement of N95 in moderate risk. So I'm keeping it as an N95 mask or equivalent. For low risk areas like admin, technician of hemat biochemistry division, serology, and those who are not at all dealing with respiratory samples, can you consider as a low risk, where you can give a surgical mask, gloves, and lab coat is good enough. A full PPE is not required in those areas. Now the standard precautions, as I think everybody with every phone calls, these standard precautions are told. So it's nothing new for you. So, but the must thing is hand hygiene. So patient should everybody should take care of his hand hygiene. That means either you wash your hand with soap and water for at least 20 seconds, or with a 60 to 95% ethyl alcohol, just as a sanitizer. Personal protective equipment whenever what is required. Eye protection is also very important, with gloves and gowns are the very standard precautions for any lab functions. Now this is how it looks like. So it can be a preferred N95 PPE, can be alternative PPE, the respiratory face mask. So this should be having like this. You can have a mask with a face shield, a full gown which at least covering the leg part, the shoe cover should be there, and also one pair of sterile gloves. Okay, so this is all together is the total PPE protection in general. So next, so these are the two coinages or terminologies we are actually very much familiar nowadays. What is called proper donning and doffing. So truly speaking, this donning and doffing, these coinages are very new to the majority of us. Donning means wearing PPE, doffing how to take off the PPE. So the proper donning and doffing of PPE are very, very, very important, because majority of health workers in a slightest mistake of a doffing or donning can lead to very disastrous outcome. So therefore you have to be very careful. So general considerations are: keep hands away from face always, limit surface touch as much as possible, change when torn or heavily contaminated, work from clean to dry, never from the opposite direction, and perform the sequential steps which I am showing you. A very basic but very important things. So this is how a donning procedure goes on. First, you check what are the procedure things you require for. And second thing, don't carry any accessories. No wallet, no jewelry, no watch, no mobile. So when you are dealing with a COVID patient sample and something very high risk, you forget about all these belongings. I know majority of them always take it as a part of your body as mobile, but for those people who are going for the test, forget this friendship with your mobile and others. So you should not carry anything of that kind. Now, whenever you're wearing the PPE, you check whether it is intact or not. Is there anything, I should say, tear or something can lead to disastrous effect. So you have to check your intactness of the PPE and quality of the PPE first, then perform the hand hygiene. First time, you perform the hand hygiene, sanitize the hand, then wear the inner and outer shoe cover first. Again, you do the hand washing, or hand hygiene. Then you wear the inner gloves. So when you wear the inner gloves, again, now it's time to wear the full PPE. Once you have done your complete, then only you use your mask N95 or what equivalent mask. You wear and check your mask whether it is fit or not. After it is complete, now you wear is your hood. That is a face shield or hood. It is complete now. Again, go for sanitization, and second time the outer gloves to go. The very important thing is that you should wear the outer gloves in such a way that the lowermost area nearing cuff, lowermost area of the PP should be under the gloves, should not hang over the gloves. So that gives you a full protection. Once it is done, check whether your every fitting is perfect. Now you are ready to go for the wall front. You are absolutely okay with. So this is the donning is much easier because donning area is not that dangerous. Now after process is done, this is called doffing of PP. Believe it or not, majority of our healthcare workers are affected because they could not properly do the doffing. So you can understand how important this doffing can be for any healthcare personnel who is dealing with these samples or these patients. All PP to be removed before exiting patient room except the respirator. And hand hygiene should be done with every steps. Now you should follow the sequential steps. So this is how you can go for a doffing procedure. So there should be area where you can throw off all the doffing in things, gloves and everything. There should be a chair where you can sit. The first you start with is same the shoe cover. So you sit there, change the shoe cover, then hand rub your hand with and sanitize your hand. After sanitizing, you just take off the outer gloves. How you actually take off the outer gloves is also very important. You actually hold the palm area of the first gloves and pull it off. And second time, you also place your finger under the gloves and pull it from inside. So that is how you now drop this. And again, you sanitize your hand. Now, slightly bend forward and take the hood off. After it is done, again you sanitize your hand. Then you remove it. This is very crucial. When removing, you should touch only the mid area, and in one shot from the abdominal area, you should take it off. And now roll it from inside and just put it in the bin. Once it is done, again sanitize your hand. Done. Then you take off both the inner gloves, again sanitize your hand, come out of this room, and after that you can remove your respirator or mask and wear again another gloves again. And finally, with that gloves, you rub your shoes properly, because shoes are also the areas where you can actually carry those virus. Now, after that, again, rub your hand and then take off the gloves. You are ready to go for a shower. Straight from doffing area, you have to go to the shower area, take a full shower. Now you are clean and you are having you're not carrying anything. You are sure of it. So any breach during this entire sequence can lead you to a hell-like situation. So that is why be very careful, particularly when you are doffing. These are the face mask. You can use a 3-ply face mask like this, or you can use a N95 procedure, depending on what kind of risk procedures you are performing or going through. Now, what is a routine diagnostic testing? What it demands? A BSL-2 laboratory using standard precautions. So these are either having automated instrument, you processing initial samples, staining and microscopic analysis of fixed smears, examination of bacterial culture, formalin fixed histopathology, molecular analysis of nucleic acid preparations or final packaging. All these are routine diagnostic, can be done under BSL-2. And therefore, specimen packaging can be done as per the CBC criteria. So now the specimen types, these are also very important. So there are so many types of specimens can be obtained. Out of them, the nasopharyngeal specimen and oropharyngeal specimens are taken at max. Other also like nasopharyngeal wash, anterior nares swab, nasal mid-turbinate swab, they are also specimens which can be collected. Now, therefore, next I go to this, how collection and storage protocol as per WHO. So for nasopharyngeal and oropharyngeal swab, you have to, transport is for everybody is 4 degrees centigrade. Now storage till testing, if it is less than 5 days, you can carry with 4 degrees centigrade. If it is more than, it will be minus 70 degrees centigrade. And rest all, bronchoalveolar lavage, tracheal aspirate, sputum, you can keep maximum 48 hours at 4 degree. If it is more than 48 hours, you have to keep it in sub-zero minus 70. So for transport of samples for viral detection, you have to take in a viral transport medium, which will help the virus to survive. Now, specimen leveling and processing will be as per the criteria of ICMR and NIV Pune, and proper leveling is a very important thing, and the least importance we give, but is a very important thing. This is what one other interesting thing you have to understand, that processed with a high likelihood to generate droplets or aerosols. If that is so, you have to wear a full PPE and other things. One of the very small thing is that centrifugation. This is a very basic thing of any laboratory, but it's a very highly aerosol producing thing. So what, first of all, whenever you centrifuge, with centrifuge safety cups should be there. And after centrifugation, keep it for 10 minutes. Don't open it immediately. Let the aerosol drop down. Give 10 minutes time and then only open, because this is also a very high aerosol generating process, is a centrifugation. Now, the specimen collection, packaging and transport as per the guidelines. So now you look at that. These are sample vials which contains viral transport medium. Now you have absorbent material, paraffin, scissor and all. Leak-proof secondary container, which is Ziploc pouch, cryo box, plastic container, etc. Hard frozen gel packs, and a suitable outer container. That should be the minimum dimension should be 10 by 10 by 10 centimeters. So that is the basic requirement. Now you should go through how to actually seal and transport the medium, because that is also another area majority mistakes do happen. So this is the process. Use PPE while handling the specimen, full PPE. Okay. Now you take the sample and the neck of the sample vial, you use paraffin to seal it. Once it is sealed, now you cover the samples with absorbent material. Now after that, you now go to stage 4, where you take it in the secondary container and then put in a Ziploc pouch and just seal the Ziploc pouch. After that, this container, you have to put it under a hard plastic container and then again seal it. You have to again seal the neck of that one also with paraffin. After that, you put it in a thermocol box with the cool gels. And after that, just what you have to do, after doing everything, it is complete. On the thermocol box, you add some other things like that, the requisition slip. You have to fill the requisition slip, put it in a Ziploc pouch and fix it in the thermocol box. Finally, if it is ready to be carried, it is a triple layer zip-locked, total care taken, and then it becomes completely safe to be taken for handling and for transport. Now, environmental specimen testing. For procedures that concentrate viruses such as precipitation and membrane filtration is ideal. BSL-2 laboratory and with unidirectional airflow, and BSL-3 including respiratory protection. So designated area should be there for donning and doffing of PPE, very important. and there should be a proper sewage surveillance. And BSL-3 laboratory using BSL-3 practice only are allowed for virus isolation. No BSL-2 laboratories are allowed for virus isolation. Now, this is one of the very important things which actually made our life a hell. That it can actually, the virus is can remain alive on the surfaces and on any metals for a few hours to few days, and therefore contact area cleaning is very important. The areas which are regular contact area should be cleaned, and you can use all the agents which are already spoken, like sodium hypochlorite, hydrogen peroxide, quaternary ammonium, and ethanol. These are the things which can be used for this purpose. And how you have to the biological waste management, that is also very important. So anything color-coded bags has to be separate color-coded bags to be given in COVID isolation wards. And although the CDC criteria is not, but ICMR has added one more criteria that you have to use 2 plastic bags. That means a double layer bags, 2 yellow, 2 red. So everything will be in duplicate. The bags should be in a 2 plastic bags to be used. Next, so anything which is stored in that part should, in the bin, it should be designated as COVID-19. Clearly should be written as COVID-19. And the container is to be taken to the another container for carriage, and that will be should also very clearly be designated as COVID-19 waste. And obviously the bin which is used for this collection should be cleaned with 1% sodium hypochlorite solution daily from inside as well as outside of the bin. So that becomes a total foolproof waste management protocol. After that, with all biosafety process, now we talk about something where all biosafety protocols have failed and you got infected, you become patient. Now you come to the biochemical markers. Already you have lots of knowledge regarding the hematology. The previous lecture was wonderful, and after that I can only add some topping on the pizza which is already prepared. So let's go with that. So my logic is, why you do the testing? So the testing has got certain logic. So you can do the test for epidemiological surveillance, you can do the testing for diagnosis, or to monitor the patient during treatment. So when you are talking about epidemiological surveillance of symptomatic, asymptomatic, already treated patients, you can deal with 2 things. Either you can go with RT-PCR, or you can have the antibody testing for SARS-CoV. Now, when the patient is already infected, so the diagnosis, so far Indian standard is concerned, diagnosis is restricted with sole with reverse transcriptase with CCR or RT-PCR testing only of the nasopharyngeal, oropharyngeal, or any other category of sample which contains the virus. Now, when the patient has infected and it's transferred to a symptomatic overt disease, now there are other tests of biochemical and hematological tests which actually give you the idea of the staging. That means, is it an initial stage of infection or it has already gone to a worsened stage? Prognostication, that means to give some prognosis where the patient is going to be, towards recovery or going to worsen the condition. The prognosis, there are certain tests which actually give some prognostic value. And therapeutic monitoring, yes, when the patient is recovering. So this also you have to monitor that the patient is coming out. So this is therapeutic monitoring. In every case, there are certain tests which we depend on nowadays. After recovery, the surveillance, epidemiological surveillance, for that purpose, you can use the antibodies, the IgG and IgM antibodies, which pretty well you can use. And if you go to the right side, no test required. etiological diagnosis, for patient monitoring, and for surveillance, as we already have discussed in that. And now, these are the certain tests for patient monitoring. So, routine lab tests for the patient who are undergoing for ARDS or DIC, you can find these things which already been discussed. This lymphocytopenia, high CRP, high LDH, raised DSR, low serum albumin, and high D-dimer, which actually signifies a worsening of the condition. Now, these are the other biochemical tests other than hematology. In hemat, you can find the leukocytosis, neutrophilia, and lymphopenia, which already I think you have got enough knowledge. I'm not going to discuss anything further. For prognostic purpose, we have to see all these things, that if the raised LDH or liver function parameters are not very good sign, with raised cardiac troponins, high PT, procalcitonin, CRP, etc., they are getting raised, and therefore low serum albumin is also prognostically not very good. Now, what are the things we are going for RT-PCR? Why do you take? Now, this a question comes now. The bronchoalveolar lavage fluid, which has a positive percentage of 93%, where the nasal swab and pharyngeal swab has got a positive percentage is only 63 and 32%. So if you take both the swabs together also, then out of 3, you are about to miss 1 patient. That means it can be positive 2 patients out of 3 patients. So they have a chance of getting false negative is also very high. But despite of that, we depend on these two only, because there are 80 to 85% are totally asymptomatic patients. So we can get a bronchoalveolar lavage only when the lower respiratory tract is already affected, number 1. Number 2, patient has to be very critically ill, because it's an invasive process. It carries risk also. So all of a sudden, just because its percentage is high, you cannot do a bronchoalveolar lavage fluid for that person. So therefore, the only so far non-invasive tests are nasal and pharyngeal swabs. Although we have a lower range of sensitivity, still we depend on that only. Now, therefore, there are certain things which already been discussed. I am not sure whether I should extend it too much, but one thing I should say, that the patient with COVID-19, as you know, this is a major problem with the lung, and particularly the insult on lung depends, and the reason behind is a cytokine storm syndrome. And therefore, one of the parameters which can be measured to give an idea about whether cytokine storm is going to affect the patient badly or not is obviously interleukin 6. And this particular parameter will come later on with a comparative study, but this one is one of the major importance nowadays for therapeutic monitoring as well as prognostic value, because it actually gives an idea of the hyperinflammation and actually gives an idea that the patient may suffer from acute disease later on. So if you look at the CT and other pictures of the lung, so elevated D-dimer seen in early COVID pneumonia, but a mass-like intrapulmonary inflammation, mass means macrophage activation syndrome, presents as lung-centric pulmonary intravascular coagulopathy, PIC rather than DIC, and you will get this ground glass appearance. Now, severe COVID-19 associated pneumonia patients with features of systemic hyperinflammation designated under the umbrella term MAC, which is macrophage activation syndrome, or you can call it cytokine storm, or secondary hemophagocytic lymphohistiocytosis, whatever may be the term, but it is because of the cytokine storm, lead to ARDS. So once it leads to ARDS, there is a chance of the major insult on the lung, and therefore there is a chance of death is very high. Now, this is depending on the level of IL-6. Very high IL-6 is a very bad prognostic indicator. Another important thing, that to start with the anti-cytokine therapy, which is called tocilizumab, this particular drug, whether to use it or not, in that case will very heavily depend on the IL-6 reports. So high IL-6 means there is a possibility to use this particular drug and it will get some benefit from it. Now, therefore, the severe COVID pneumonia, you can get all these things: abnormal liver function, hyperferritinemia, coagulopathy, and high CRP. So these are the tests which can come, which actually you can get very commonly in severe COVID pneumonia. Now you see, these are the things, relative load. White blood cells, in case of severe, the red lines are severe group and the black lines are mild group of disease. So you see, there are certain things which are very distinctly common. Is a lymphocytopenia. At the third stage of illness, lymphocytopenia is very low lymphocyte counts you can get, and so the granulocyte lymphocyte ratio will be very high, and therefore you will have a drastic difference of granulocyte lymphocyte ratio in case of particularly difference between severity and mild group. Similarly, C-reactive protein, which surges very high in the case of a severe pneumonia. Another CT scan scores. If you score the CT scan, there is a marked difference between the CT score for a severe as well as a mild case. Now, the 3 points, now coming to the final areas. 3 protein biomarkers are very important, and nowadays, now you have to see what are the importances of it. Interleukin 6, it has got, already I have said, this is very important as a prognostic marker, and also during the phase of recovery and gradually coming down IL-6 is a very good indicator. So you can use this as for to assess the patient's prognosis as well as for therapeutic monitoring. Now another role is coming up procalcitonin. Procalcitonin initially doesn't rise so much. So we are not talking about procalcitonin very much in this case. And it is similarly like H1N1. Procalcitonin has got a lot of different roles. So you have seen that those who are already getting ventilated, this COVID-19 has got ventilation associated death is very high, near about 99%. And it is usually seen that a secondary bacterial infection like a septopneumonias are very common when there is a COVID-19 pneumonia. So these cases, it actually procalcitonin helps for antibiotic stewardship. When you can take a decision, procalcitonin usually rises very high when there is a bacterial infection or sepsis along with. So giving a broad spectrum antibiotic or choosing an antibiotic, procalcitonin can be of big help in those cases. And CRP right from the beginning, it's an acute phase reactant and also rises very highly, induced by IL-6. So there are systemic marker. It carries less specific importance rather than IL-6 and procalcitonin, but all three are very important markers in this disease. Now, so this is for the pediatric age group. Unlike adults, the laboratory profile in severe COVID-19 pediatric patients, not very clear, not consistent with SARS. A recent publication recommends clinicians monitor lymphocyte count, C-reactive protein, and pericalcitonin to assess severe infection. IL-6 should be considered to be investigated as a potential pediatric prognostic indicator like the adults. And there are a preliminary description of pediatric is published in CBC already. And it is seen that the pediatric cases reported with less severe compared to the adults. And CDC recommends clinicians maintain a high index of suspicion for COVID-19 infection in children and monitor for progression of illness, particularly among infants and children with underlying conditions. So therefore, I'm almost finishing my part, and these are the references. And my sincere heartfelt thanks to my colleague, Dr. Barnali Dash, for helping me out to prepare the slides within a very short period of time. Teresa also, and my beloved juniors, Sharmishta, Shubhranshu, and Navneet, for giving their immense support and enthusiasm to make me capable of giving this lecture here. Thank you all. And thank you for listening.
This will be of use to everybody. So now is the time for question and answers. I will request Varun to ask both of the the panelists their respective questions. Varun.
So, good evening, dear speakers. Now that both of you had very nice session, we have, hello,
Yes, yes.
am I
Varun,
audible,
go ahead.
Priyank?
You're audible for sure. Go ahead.
Hello, Priyank, am I audible?
Yes, you are audible, Varun.
Okay,
Go on, please.
yeah. So we have questions. I will start with Dr. Handu first. So one of our participants, yeah. So one of our panelists had asked that hemostatic parameters from coagulation, which are the parameters which can be used to monitor COVID patients.
Okay. So as far as hemostasis testing is concerned, as I mentioned in my presentation also, the parameters which are of paramount importance, amongst them, if I have to just choose one single test, then I would just go for a D-dimer. And serial values of D-dimer is extremely important. What is also important to realize is that I have also recommended, if you see my presentation, if you would have noticed in my presentation, I've also very clearly recommended that there is a requirement of following up what is called the DIC score. And that DIC score, prothrombin time and platelet counts also play an important role, and so does fibrinogen. So if I may want to summarize the whole thing, what I would like to do is do a platelet count, do a prothrombin time, do an activated partial thromboplastin time, fibrinogen and D-dimer, and take this as a single profile, what we call a coagulation profile, monitor it on a regular basis. May not be necessary that I will do all the tests all the days, but I would want to do D-dimer all the days for sure. And then based on my D-dimer levels, I would like to take my next course of action. So that's how the hemostasis will end. But let me tell you very clearly, hemostasis parameters are not diagnostic. They are only indicators of prognosis, and they are indicators of severity of the disease.
अंदर जाओ बाहर मत आना जब तक हमने बुलाया.
Yes, Varun, we can hear you.
Okay,
Next
sir,
question, please.
there is another question from Benno Queenie, one of our participants. That So plasma therapy for COVID-19 patients. What is your opinion on this?
Okay, so I think plasma therapy, convalescent plasma therapy to be more precise, is what people are talking about. It's not only us in the country. I think a lot of people abroad have already spoken, done, and proven that it is of some degree of benefit. But let's understand very clearly, it's still an experimental therapy. It is not a therapy which has been proven against a case-controlled trial or stuff like that. So practically speaking, it's been assumed that there are these antibodies which are present in the convalescent plasma, and that convalescent plasma-based antibodies are eventually going to help a person recover. How much is the reality in that needs still to be seen. ICMR has come out with a very interesting project on that, which a lot of people are already a party to, and some of them are becoming a party now. And hopefully in due course of time, we'll get to know the results. As far as my personal opinion is concerned, if you have nothing else, what else can you do? You still have something to give to the patient, and this probably is going to help you, may or may not be. So we have to use it with a thought in our mind very clearly that probably we're dealing with something which is experimental. It may have a desired result or it may not have a desired result. And another important aspect, getting group specific plasma would be a biggest challenge, because it's not necessary that you will get plasma which is of the group that you need. And that could also be a possible potential. Please remember that when you're giving plasma, you're also not only giving the antibodies which are supposed to be anti-COVID, you're also giving a lot of other things with plasma to that individual, and possibility of plasma-induced coagulation disorders and other disorders, like for instance, Trali and stuff like that, also needs to be kept in mind. So it comes with its own risks, but at the same time, if you have nothing else, this is the only modality of therapy that you have. Varun.
Varun, next question, please.
There is, yes, sir. There is another question that this, So is lymphopenia also observed in asymptomatic cases?
No. So if you look at lymphopenia per se, lymphopenia is not a feature of asymptomatic patients at all, because lymphopenia does not come alone. It actually comes along with neutrophilia. So there is neutrophilia and concomitant lymphopenia, which is usually a feature, and this is usually a feature of symptomatic disease. Asymptomatic individuals do not really come with lymphopenia. In fact, asymptomatic individuals hardly have any evidence of, other than the RT-PCR positivity, which you will be able to find in such cases. You will not be able to get any other investigation which is, giving you a result which is probably diagnostic, or even for that matter an indication or a screen. Having said that, patients with who are asymptomatic eventually will need to be monitored, only for the fact that if they start getting symptoms, and that is the point when these investigations will become important. Varun, you can go ahead.
Yes, Varun, any other questions?
Dr. Barnali Das had asked both of our speakers that are you using hydroxychloroquine? Yes, sir. Yeah, there is one last question for Dr. Anil Handu from Dr. Barnali Das, that are you using hydroxychloroquine prophylaxis in your setup?
Okay, so I have used hydroxychloroquine as a prophylaxis for myself. As a policy of the organization, this has also been extended across to everybody in the organization. However, before going ahead with hydroxychloroquine therapy, there is a very clear-cut form which has to be filled up, in which you have to declare all the possible interactions which can potentially come up for hydroxychloroquine in your own individual. We have also taken what is called a baseline ECG for everybody who took hydroxychloroquine, including me. And so far, God has been kind. My HCQ part of it has not really given me trouble. And I think I'm on my last dose now. Perhaps next week it will finish off for me. I hope that answers her question. Dr. Sushruth, do you want to add something for this? You'll have to unmute.
Hello. Hello.
Yes, now we can hear you.
Yeah. Actually, sir, the similar thing of my hospital also taken the similar type of steps. Actually, we have given a form declaration consent form, actually, where we are taking and what are the things can happen in hydroxychloroquine side effect, that has been clearly made understood to all of them. But what I personally feel is actually, I have taken hydroxychloroquine. I'm taking hydroxychloroquine for quite a few days. Not only whatever, if it takes care or it doesn't take care, I don't know. But in this condition of COVID-19 menace, so if it gives some psychological belief or psychological strength also, that is also important for us. So otherwise, the same protocol that followed, actually we are carrying out an ECG also, particularly, but not for all, those were above 45. Hello?
Yeah, yes, sir, we can hear you. Sir, Dr. Handu, sir, there's one question on the YouTube which says viruses generally cause lymphocytosis. Why lymphocytosis in case of COVID-19? Question for Dr. Handu. Yeah, he means lymphopenia. Correct, sir.
Well, actually, if you look at it, it is not really lymphopenia to start with.
Lymphopenia.
Yes, I got your point. So if you look at the literature very closely, what you'll observe is, while there is lymphopenia, which eventually does set in, initially it's not lymphopenia, initially it's neutrophilia. So lymphopenia, why does that exactly happen? There is a pathophysiology which has been mentioned in it, and a lot of it has got to do with ACE inhibitor receptors, more prominently on the lymph. However, all this is still speculation. I am honestly really not very sure as to why does this happen, but this is a very unique kind of a disease where we are seeing this happen. Having said all this, also you need to remember, even in my presentation, I have shown that there is presence of these reactive lymphocytes, which we see normally even in dengue kind of an illness also. So I think food for thought. Maybe we will get more answers in eventual times. But right now, no specific answer as to why does it cause only lymphopenia and why doesn't it otherwise? Because for all of the viral illnesses, generally you will see the lymphocytosis. I agree with you.
Thank you so much, sir. Varun, any other questions? Okay, so let's move to the final, part of the event.
Thanks, Dr. Adil Handu. So these were the questions for you. Now we have some questions.
Yeah, thank you, Varun. So, sir, first of all, we would like to thank both of the speakers for
Priyank, hold on. There are some questions for Dr. Sushu Sen.
Okay, please. Sorry, tell me. Go on, Varun.
Yeah.
Priyank, hold on.
Yeah.
Okay. So Dr. Sushu Sen, there is a question from one participant, Santosh Verma, that during the doffing process, the room and chair might have some aerosol which can be dangerous for the next person using that room. So how do you suggest to disinfect that room?
So any doffing area, after the person has come out, there should be having a spraying facility, or at least the contact areas has to be cleaned with the disinfectants. So that is a routine protocol. Okay. So whenever you are coming out of the doffing area, that entire area has to be sanitized before the other person coming in the doffing area. So that is automatically that takes care of this. So if you have got the sprayer gun, then it works best. And otherwise, you can also have some contact area decontamination process also. But doffing area, once the person left the doffing area, there should be a spraying, cleansing with the spraying actually, with the gun. That is the best, that works best actually. It's a very pertinent question that there might be something left. That is when I'm saying that it's the dirty chair. Don't sit once you have doffed your gown. So that is the area you have to take care of, obviously. But I don't think if you sanitize properly with after every process, any droplet will remain. Hello.
Sir, there is another question from Dr. Sucharit Mohanty that how do blood gases and electrolytes behave in COVID patients?
It actually doesn't have any specific criteria of that. So if the lung has been affected very badly, obviously you will have a saturation drop. PO2 will be saturation SpO2 will be dropping, and obviously sodium potassium, this can be aware if some other end-stage renal disease and all other, what I say that if it is a multi-organ failure later on, so it will have its effect on sodium potassium later on. There is nothing very specific as of now which you can actually diagnose to be a COVID-associated hyponatremia or hyperkalemia or something like that. Like all other sepsis cases, if there is a multi-organ failure.
Sir, one last question from Dr. Samarpita Mukherjee from Woodland.
Go on, Varun.
Yeah, please.
One last question from Dr. Samarpita Mukherjee from Woodlands Multispecialty Hospital, that IL-6 is a prognostic marker for severe disease when the cytokine storm sets in, or we can use it in the early phase of infection also. Associated with this is there any role of interferon, basically type 1, as a prognostic marker?
See, this is for cytokine storm, whoever other type IL-1, IL-6, they all can be prognostic marker. But depending on the availability, IL-6 test and now has been validated and used very regularly. But for early phases, when the patient is in asymptomatic phase or a very mild phase, doing IL-6, I don't think will be of much help. So when it actually starts, the cytokine storm starts building, and when the pulmonary areas are getting affected, and during that time, if you start IL-6, doing IL-6, it will be, I think, it will be better, because you can do it from day one, doesn't matter. But to give a specific importance of one investigations, it should be done on proper time. It's, as of my call.
Okay. Any other questions, Varun?
Thanks a lot, sir. These were the questions.
Thank
Okay.
you.
So from the behalf of Mindray, I would like to thank both of the speakers and the attendees for attending this session. For our final session, I would like to invite Dr. Mosmi Shekia. She's the General Secretary, Dental Committee for ACCLMP. Ma'am, over to you. Thank you.
Am I audible?
Yes, ma'am. Loud and clear.
Yes. Thank you, Mr. Priyank. Good evening, everyone. This is a great honor and a privilege to deliver the vote of thanks today at this webinar on behalf of ACCLMP. First of all, let us take this opportunity to introduce ourselves to this platform. And myself, Dr. Moshimi Sekia, I'm the General Secretary of the Association of Clinical Chemistry and Laboratory Medicine Practitioners. On behalf of ACCLMP, I would like to express that we have been able to make our first webinar a huge success. More than 200 participants registered for this webinar. Now, I would like to express my heartfelt gratitude to our honorable guest speaker, Dr. Anil Handu, who has been very kind to accept the invitation for the lecture. I'm sure we have some valuable takeaways from Dr. Handu's insightful presentation. I would also like to thank our speaker, Dr. Susruta Sen, the president of ACCLMP, for enlightening us with his excellent presentation. I would like to express my sincere words of appreciation to all the esteemed members of ACCLMP for extending their timely support. I would like to thank our distinguished guest attendees as well, who have attended with throughout this academic session. Last but not the least, thanks to Mindray for associating with us, and special words of appreciation for the excellent team effort and team support, especially from Mr. Diptanuj, Mr. Priyank, Mr. Varun, and everyone in Mindray. Thank you all once again. Looking for some more webinars in the near future. Thank you.
Thank you so much. Again, just wanted to remind you, the recording of this webinar will also be available on Mindray India YouTube channel. So I will request anybody who is interested for further referencing to go to the channel, subscribe, and all our webinars are also streamed live on the same platform. So thank you. Thanks again, and have a good evening. Thank you so much.
Thank you, everyone.
Thank you, sir. Thank you.
Thank you, Dr. Sushrut. Bye-bye.